the next bugaboo of the male anatomy, the prostate gland. I'm going to say it again. The prostate's between the urethra and the penis and the bladder. It's just part of sexual function. It contributes to seminal fluid. I think it adds like 10 or 20% of the seminal fluid. And bladder, your urine must go through it. Mm-hmm. And unfortunately, it seems that in men, the prostate grows over time.
That's right.
And it can constrict the urinary flow. So it causes a lot of problems. And I see all these ads on TV for prostate treatments, prostate medicines, prostate herbs, all this stuff in the middle. And they're on in the middle of the night because they know we're getting up to pee in the middle of the night. So tell us a little bit. Let's talk prostate for a little bit, Clyde. Is it true that if a man lives long enough, he has like at least a 70% chance of getting prostate cancer? Is that a number?
That's true. Yeah. I mean, once you get into your 80s, 90s, usually it's the slow, by that point, if you're asymptomatic, a lot of times it's the slow growing.
Okay.
So it might not ever affect you in your lifetime, but it could. If you're a good, healthy 80-year-old, it could still affect you. Okay. But if you were just to do autopsies on everybody and they died of other causes and they're 80 to 90 years old, you would find something like that in terms of the...
I'd say 70% a number.
Yeah.
If you look harder, I know that 15% of the time you'll find something in the pituitary, unrecognized. All comers. All comers. Now, as far as screening for prostate cancer, I think the go-to thing that everybody talks about is the PSA, a blood test looking for prostate-specific antigen. Is that generally what most doctors do to screen for prostate cancer, or is there a role of a digital rectal exam by a primary care or urologist?
Yeah, so there are two things that we recommend for screening for prostate cancer, and that's what our national guidelines say, at least in urology, and that is the PSA test and the digital rectal exam. And neither one is perfect, but it's a very inexpensive, simple test, and it's a good start. So our goal with any type of screening is to find something before it's a problem, before it's spread or there's more morbidity associated with treating it. So the PSA is a natural protein that's found in all prostate cells, but the cancer cells tend to make more PSA.
Okay. That's why you don't have zero. You don't walk around with zero.
Right.
You walk around with 1 or something.
Right. And if you have a bad infection in your prostate, the number could be very high because those cells are damaged and they're leaking that PSA out.
So it's not always cancer. You get what's called a false positive.
Right.
Now, do you think family doctors or internists or somebody do enough prostate exams for the digital exam to be even meaningful?
Well, unfortunately, a lot of them don't do it at all. I mean,
I've noticed that.
Patients come and nobody does it. Nobody has it.
Right.
And, I'm sure there are other reasons besides urology to do a rectal exam. I mean, rectal cancer, all these kinds of things.
Rectal cancer. My goodness.
It's surprising that, people don't get a yearly check. But what we're looking for is advanced bad cancer. Very hard, large nodule or rock, something that's saying, whoa.
So any competent, experienced primary care doctor, he or she should be able to feel an obvious rock hard abnormal prostate.
Yeah.
Now, obviously, a urologist like you who does literally millions of the exams, you're obviously going to be able to feel something a lot smaller or more subtle.
You are, but I mean, it's really not feasible to send every human urologist just to get a check.
Right, exactly.
So, it's something that I think should be in the realm of family practice. I think it's important to do the screening. Really aggressive, high-risk prostate cancers, just because you think of cancer, you think the more they are like a stem cell, the more aggressive they are. So they actually stop making PSA because they've changed so much.
Anaplastic. They've lost their characteristics.
So you may feel a hard rock, and their PSA is 2. And they have
which is low.
Gleason 9 or 10, a very, very aggressive prostate cancer.
Gleason is the scale you use to judge.
So they have a bad cancer, basically.
Stage.
Yeah. So you should do both.
So PSA could be false negative in that situation. False negative.
Yeah.
Interesting. So, any thoughts of why does the prostate gland generally grow in most men over time?
It's just,
Right.
yeah.
People talk about testosterone and estrogen and cortisol. I see all these different theories out there, depending on what bottle of pills somebody is hawking or trying to sell. What's your understanding?
Yeah, well, it's
please?
clearly testosterone. I mean, testosterone and androgens are what stimulate the prostate to grow.
Now, would that be the super strong testosterone derivative, dihydrotestosterone? Is that
Right,
part
so
of it? Do you think
DHT,
too?
Yep. That's what, when you're developing as a fetus, that's what stimulates the sex characteristics. The phenotypical male is that DHT. So that's a downstream metabolite of your testosterone.
Okay.
So, and we can talk. I mean, that's where some certain drugs work.
Yeah.
Like finasteride, one of the common drugs we use to treat an enlarged prostate. It blocks the DHT.
Now, are there side effects with the finasteride? Or does it make you weaker? Do you lose muscle mass?
You don't lose muscle. Actually, your
sex drive?
testosterone level may go up on the drug. Just
Interesting.
because you're blocking
Paradoxical.
it. Yeah. But about 5% of people will have a significant decrease in sex drive or libido. And some people that's pretty severe. I mean, could have some other sexual side effects, erectile dysfunction as well.
Is it bad on the liver? Maybe.
The finasteride?
Yeah.
I mean, if you have a normal liver function. Now, testosterone is hard on the liver.
Ah, okay.
That's why we don't take, for the most part, we don't take testosterone pills. We do shots, injections.
So it doesn't go through the liver as a pill.
Right. You miss that first pass through the liver.
Gotcha.
For the metabolism.
So the growth of the prostate, in your understanding, is testosterone and dihydrotestosterone, not necessarily cortisol or estrogen. I've heard all kinds of theories from a lot of different places.
Yeah.
And I just didn't know who to believe. Or I also hear this just an inevitable part of aging. It's going to grow no matter what.
Well, the stimulus is testosterone because that's what we do when we treat prostate cancer. We block your testosterone to stop the cancer from growing. And
that makes a lot of sense.
And there's no debate there. I mean, this is
cut off testosterone that tends to
studied
shrink
for decades,
and it slows down.
Yeah.
Interesting. So, let's say a guy has this, and the common term for the common prostate growth is called benign prostatic hypertrophy, or BPH, right?
Right.
So it's not a cancer; it's a common problem. And I understand you have lots of different treatments or things you can do for men with an enlarged prostate.
Yeah.
So maybe you can take me through this. You've got, I see on TV, they've got these things for a Eurolift. They've got something called a TUNA, a transurethral nerve something ablation, needle ablation. That's TUNA. Needle ablation. Can we talk about those?
Yeah.
And the steam treatment. Can we talk about those first before we go on to TURPs?
So when we break down minimally invasive treatment options, there are things that we do to try and replace medications or do in guys that don't want to take pills with potential side effects for the rest of their life. Because that's what we're talking about with pills. It's not like an antibiotic you take for an infection for a week and it goes away. You've got to take these drugs forever, So one of the things we can do besides those drugs is a minimally invasive treatment. So first line, we have drugs or these treatments. And these treatments are going to be Eurolift, Resume, and
Resume, is that the steam? Is that the steam treatment?
And there's a newer one, which is basically a stent called iTend. Okay.
A stent, a tube?
Yeah. It's a temporary. We leave it in for about 5 to 7 days. So just to break those down, because it's a little confusing.
Yes, please explain.
The Eurolift is basically works by, as the prostate grows, it pushes the walls together. So if you're trying to blow through a straw and I squeeze the sides of the straw together, it'd be hard to blow through.
Okay.
Well, that's what your prostate's doing. It's kind of like a trash compactor. The walls are caving in or squeezing together as it's growing. Mm-hmm. And then so that tube becomes a slit now that you're trying to pee or urinate through.
Okay.
So what Eurolift does is it pushes that open. And we use small implants that will pin it open. So it's basically like pulling the curtains back, and that's going to hold it open.
Well, how long will it hold it open?
Well, maybe forever. retreatment rates, we have a, good 5-year data on these things, and, it's pretty good. It's not going to be the same as a roto-rooter or a TERP.
Yeah, we're going to get to that in a
Which
second.
we'll talk about, which is a more aggressive surgery. But, we're talking about replacing medications. We're talking about something with no sexual side effects, which is important. in men.
Okay.
So we're talking about minimal side effects for something that maybe isn't quite as aggressive as a bigger surgery, but may work very well for many years.
So you have a growing experience with UroLift.
Yeah.
And it's basically favorable?
I think it's very good in the right patients. The problem is it's not one size fits all.
Okay.
Prostates come in all shapes and sizes, so you have to take that into consideration. It works better for certain prostates than others.
Okay.
So there's an evaluation I do in the office where I look in there with a little telescope and an ultrasound and measure the size of the prostate, and we say, what makes sense for you? This might make sense. But maybe it doesn't. So you have your prostate's not shaped that way. Well, then there's another treatment called Resume.
What is that?
So that's the steam treatment. So basically, it's kind of like a newer tuna, where I go through a telescope where I can look in, just like how we used to, treat the stones. We go in with the telescope, and through that telescope, a little needle goes into the tissue, and water vapor comes out. Steam. So it's a thermal therapy.
It's hot.
Yeah.
Okay.
And that treats a 1 centimeter ball, or spherical area, and then over time that will shrink down. And we treat a couple different places around the urethra. So then as that shrinks down over time, it's going to open up that channel, take pressure off that tube.
Now the prostate comes in various lobes, right? So would that be for more of the middle lobe that's around the urethra?
It's for the middle part of the prostate called the transition zone. That's where we tend to see the benign enlargement. There are lateral lobes. That's where the walls are coming together. And then there's also going to be a middle lobe, which is like a cork in a bottle. It's growing right into that. That's one of the worst situations.
Boy, it sounds complicated to evaluate.
Yeah. So you want to have you want to do an evaluation and see what's going to work.
So has this ablation, the steam treatment, has that superseded the tuna? Is that like better? The Resume, is that better than the?
I mean, I don't know if it's better. I think most people just do it now because one, it's direct vision. I can see exactly where that needle goes. It's more readily available.
Are you talking about the Resume?
Yeah.
The steam?
Yeah, versus the tuna. Yeah.
Okay.
And then next is something it's newer called I-10. So I-10 works by we go in with a scope and we deploy a stent, which is basically has 3 wires. Think of like a Mercedes symbol.
Okay.
So there are 3 wires. One goes up and then one to each side. And those expand when we deploy it in the prostate. And as they expand over the course of 5 to 7 days, that wire will go through and make a groove. So we're making 3 grooves in that prostate to help the flow. And because it's pressure, you have less bleeding. It's almost, a bloodless. You're not incising or
and then
cutting
does that
out.
come out?
And then you take it out 5 days later. Yeah. So, and the 5-year data is looks pretty good on that when you compare it to taking medications, and minimal sexual side effects. So, yeah, I think it's important to remember these are a bridge or something to replace medication. They're not better than a TERP. They're not something to replace a TERP or a laser surgery on the prostate.
Well, that's the perfect segue to the TERP. The TERP is I guess the go-to or the workhorse treatment for an enlarged prostate, where you put a telescope under anesthesia, you put a telescope up there, and actually use a cutting loop and actually cut out or core out the prostate with electrosurgery.
Yeah.
Is that a more permanent solution, or what are the benefits of a TERP?
Well, the benefits of that is, one, it's has probably going to be better long term for people with severe symptoms, urinary retention. In other words, they went to the ER. They couldn't go to the bathroom at all. They had to have a catheter put in.
And that can back up to your kidneys
Right.
too. That can have
Cause
life-threatening
serious-
problems.
Right.
It's not just an annoyance.
And they tried medications and they can't get the catheter out. They just can't go. So they're in this severe category. I mean, it's a bad blockage. And so we're not going to necessarily mess around with these minimally invasive things that are less likely to work in those individuals. That's where something like a TURP comes in, because we're removing that tissue immediately. When you wake up from anesthesia, the tissue is gone. So, hopefully within a day or two when you get your catheter out, you can urinate.
So recovery can be that quick with a TURP.
In terms of being able to urinate, yeah.
To urinate.
Now, there are some other things, basically burning when you urinate, some irritative symptoms or blood in the urine that take a little longer. Just like if you scrape your knee or your elbow,
Sure.
the lining grows back inside. It takes weeks.
Takes
for
weeks.
that to happen. Yeah.
With the chance of, but what's the chance of incontinence in an experienced surgeon's hands?
It's going to be very low. We say 1% to 2%. I mean, I think that's probably even high for the way we do it now.
So the risk of, if you catch it early, you don't have any complications, you don't have a cancer, et cetera, you don't have diabetes and whatnot. The regular healthy guy should have less than a 2% risk of incontinence.
Yeah.
Now, is there diminishment in sexual function?
There is. So there's a good chance that you will not ejaculate anymore.
I've heard that it goes backwards, called
Goes
retrograde
backwards. That's
ejaculation. Okay.
Right. It doesn't hurt you. If
Right,
you're not
right,
trying
right.
to make babies, it's not going to hurt you.
Gotcha.
You just urinate it out later. In terms of the nerves that go to the erections,
Uh-huh.
with the technology now, it's pretty uncommon. I never tell a patient there's no possible way it could ever happen, but it would be very rare because the energy is much less now, and it's so focused on the tissue, a millimeter away. It's not going to travel all the way through
Not going to
to the
spread.
nerves outside the prostate.
So the TURP is the one that the go-to surgery that most urologists have experience with.
It's definitely been around the longest,
Okay.
yeah, and it's something you do a lot of in training. Now, a lot of us use lasers.
So what's the difference between laser and electrosurgery? What's
So-
the difference?
Yeah, basically with a laser, we're using a laser to vaporize or ablate the tissue or to cut the tissue. And so by ablating it, we're basically shaving it down, creating that channel. And so a lot of times there's less bleeding with the laser. And so sometimes we can even do people on blood thinners that have a hard time coming off of them with laser surgery.
Interesting. And is there a lot of, do you have to go to a specialist with laser, or do most urologists?
A lot of
use
urologists now coming out training have experience with lasers.
with laser as
Pretty
well?
common technology. yeah.
Laser as well. Interesting. So prostate enlargement, prostate issues, probably just a part of life, and not much we can do to prevent it, but we can certainly have lots of methods to treat it.
Yeah.
In experienced hands such as you.